I would like to introduce you guys to our speaker for this session. Dr. Joshua Wolf is a transplant nephrologist at Piedmont Transplant Institute who specializes in kidney diseases and transplantation. He is also a member of GTF's board. Dr. Wolf has a special interest in living donor transplantation as well as improving access to care through telemedicine. He is board certified in nephrology by the American Board of Internal Medicine. He received his undergraduate and medical degrees from Emory University School of Medicine, completed his internship and residency at New York University Medical Center, and his general and transplant nephrology training at the University of California, San Francisco. Without further ado, please welcome Dr. Wolf.
Thank you, Nika. That was a very nice introduction, and I enjoyed hearing the overview of what Georgia Transplant Foundation does for their patients. And thank you to Georgia Transplant Foundation for allowing me to speak today. They're really a wonderful foundation. I've been on the board for, I think, over 10 years now, and really had a chance to get to understand and see what they do for our patients throughout the state of Georgia. So to start, I see a lot of familiar faces here, and I know we have a lot of people who've received kidney transplants because many of you are patients I've taken care of. Anyone here waiting on the waiting list or trying to get on the waiting list to receive a kidney? All right, good. So that's great. Hopefully some of the people on Zoom are as well, because I'll be honest, a lot of my talk is about pre-transplant. I do have some post-transplant slides, but hopefully even those who've received a transplant will see how the scope of the evaluation process has changed. So, just looking at barriers, the evaluation, living kidney donation, finding a donor, kidney paired exchange. There's a lot of changes with organ allocation, which has allowed a lot more kidneys to come into Georgia, which many of you may find interesting. You may have heard these acronyms, KDPI and EPTS, what they mean. And then I do want to talk a little about COVID, because there have been some changes with approach to transplant care and some important things for those of you who received a transplant should know with regards to that. So this slide I've used a couple times. I'd say probably now there's almost 1 million people in this country, probably closing on 1 million, who have end-stage kidney disease. When you look at population groups, the highest growth is between ages of 45 to 64, where the highest incidence is over 65 years old. Now, when we're seeing folks referred for transplant, we're seeing an older population. People have multiple comorbid conditions like heart disease, diabetes, vessel disease, neurologic problems. And a lot of people with complications of end-stage kidney disease, vascular access problems. And then also we're seeing many folks who are looking to receive a second or third or fourth kidney transplant. So this is there's a couple of different other groups that you can be aware of. SRTR is a big one. I think someone's talking about looking at how do you find out how many transplants different programs have done. And SRTR, Scientific Registry of Transplant Recipients. OPTN is Organ Procurement and Transplantation Network. Those are really good resources to look at data on different centers. So when you look at adults waiting for kidney transplant, you'll see that the highest group at the top here is ages 50 to 64, that's in red. And then you'll see that 35 to 49 has been decreasing, but then ages 65 and up is going up. And I think a lot of that is just really better healthcare now. Folks who have cardiovascular disease are living longer. They're making it to the point of going on dialysis and eventually being eligible to receive a kidney transplant. So what are options? Well, most people in this room are probably familiar with these options, right? You have hemodialysis, which you can do at home. You can do in the center. You can go to the center and do it at night, which is, I probably don't need to go into detail with that. Then there's also peritoneal dialysis. But when you look at these two dialysis modalities, they only really work for about 10 to 12% of actual clearance compared to having two normally functioning kidneys. So then you have transplantation, looking at living and deceased donors, which we'll talk about. And I'll show you in a minute that kidney transplantation, obviously everyone knows here, it's going to give you a better quality of life. But not many people realize we have this for those who've been to Piedmont in our exam rooms to look at actually how much longer do you live with a transplant than being on dialysis. Yes?
I'm sorry, I want to interrupt you. How long has it been since you can do hemodialysis at home?
Oh, it's probably 20, 30 years.
2004.
Yeah. It's been a long time. Yeah. So when, and again, so I can tell you a little about it. I'm not a general nephrologist, so I don't actually care for folks that do this, but it really does require a support person at home. You really, well, highly recommend it.
I would say and I will give a disclosure. I actually work for Next Stage Medical, makes the machine, and I'm an expert who did it as well. I was basically solo. My mom did go through training with me, but we promote solo. It's just a lot more training, and there's extra precautions that we
Right.
have patients.
Yeah, I get nervous with, so again, I don't manage this, so I'm probably the best person to ask, but I always get nervous with solo if your blood pressure drops overnight or someone gets
You don't have
lightheaded.
as much as you do insert,
Yeah,
because you're not pulling as much, and the machine pulls different.
right.
Whereas I had a lot of hypotensive episodes in center, had none in 5 years at home.
That's something that you should talk about with your general nephrologist to look at options for that. But there's for me as a transplant nephrologist at Piedmont, I just do acute dialysis. I don't do any chronic dialysis. So you can probably answer more about this than I can.
Yeah.
You go on to the next slide. So this is really, I think, important slide to look at survival, right? So as you can see here, this y-axis here is age, 75 to 79, 20 to 24 at the top, if you guys can see that. This breaks down by age groups. And orange is the 50% survival on dialysis, and then blue is the 50% survival with a transplant. So obviously, this gap is going to get smaller and smaller as you get older and older, right? But if I see somebody, oh, they didn't update my slides. This is not an updated slide deck. I sent to Rebecca yesterday. These times are wrong. I updated this yesterday. I guess you didn't get it too. So I would say in Georgia now, A to B is waiting about 1 to 2 years. A is probably 4 to 6, and B and O are 6 to 8. So
That's a
Yeah.
good way to go, though. Better than.
yes, it's better, and I'm going to go into why the times are shorter. But and some of you can attest here that it's been even shorter for you on the waiting list, and that's a whole other talk that I could go into. If I can answer that later. But if you take like someone who's 60 to 65 years old, their blood type is B. I know it's hard to see here, but the 50% survival here is about 5.5 years. So when I see them to evaluate them, I'm like, look, your 50% survival on dialysis is 5.5 years. Your blood type is O. The average waiting time is 6 to 8 years. Your chance of being healthy enough to receive a kidney off the waiting list is going to be well under 50%. And so that's going to like why we push a lot with living kidney donation. So next. So with the pre-transplant, I'll kind of go through this quickly because I think a lot of people are post-transplant, but it's a really multidisciplinary approach for those who've been through the evaluation process. You're going to meet with financial coordinators, your pre-transplant coordinator, social worker, dietitian, nephrologist. And then when you go through the evaluation process, we'll probably recommend additional testing outside the evaluation, cardiologist, possibly urology clearance. And then, once we get that, we meet with a selection committee. We make recommendations on exactly what you would need to do to get listed. And then hopefully get listed. If you have a living donor in that time, hopefully bring a living donor in. We can be evaluating the living donor and hopefully we'll schedule a living donor transplant if you have a living donor available. Next. So why are people excluded from transplant? Well, this is a little bit of a dated slide, but it's pretty much consistent. You'd see that the highest is, is medical contraindication. Perhaps someone's had a recent cancer, or they have significant vascular disease. There have been, insurance I think is getting better. It's at 5%. Most insurance companies are now understanding that the cost of paying for transplant surgery and medicines is way less than paying for dialysis. Obesity, which I'm going to talk about as well. Oftentimes patients decline when they look at, what it would involve with going through transplant, taking medications versus staying on dialysis, or maybe they're not on dialysis yet. And 8% is kind of unknown or unspecified when you look at this stuff. Next. So, the standard waiting time for transplant is, I mentioned earlier, is about 2 to 5 years. Liver cancer, if someone we diagnose with that, we're often going to have them see our liver transplant team to be evaluated for potential liver transplant. One area we don't see this a lot, fortunately, is multiple myeloma. And that is because not the surgery itself, but the medicines we put you on afterwards lower your body's immune system, so your body or your immune system won't reject the kidney. And with multiple myeloma, if we're lowering your immune system, that can make the cancer worse or spread. And then, different cancers are evaluated in different amounts of waiting time. So I will tell you that if it is malignant melanoma, oftentimes that could rule you out, or if it's what's in situ or very early stage, it may be a 2 to 5 2-year wait. Breast cancer, cervical cancer, colon cancers all really depend on the stage of that cancer. And usually we're getting an oncologist involved to help us with those recommendations. There are some good studies out that have some guidelines about that as well. And that's really going to be like a center to center decision. But usually, like I said, we'll be getting an oncologist or cancer specialist involved. So what are general exclusions? So severe cardiovascular disease. And then I had my newer slide deck, another bullet pointer there talking about CT scan. So at our center, we do a CT scan on everyone that comes through regardless of age. And really the big reason we're doing that is, yes, we can pick up some cancers, but more importantly, we're looking at vessels. And we want to know, does your vessel have diffuse calcification, like throughout? Because if you think about it, the surgeon can't cut through a calcified vessel and suture that. And so that's why, that can rule people out. Also, everyone's getting echocardiogram. Look at your ejection fraction. How well is your heart pumping blood to the kidney? If your ejection fraction is really low, you're not going to get enough blood flow through that kidney, and it's not going to work. And many folks are going to get a stress test to make sure your heart can undergo the stress of surgery. Again, I kind of mentioned the malignancy part, being referred to a specialist, an oncologist, to make some recommendations on how long someone may need to wait after being treated for their cancer. Active infection. So if somebody comes in, diabetic with an active wound or ulcer, then we're going to want to wait to complete their evaluation because, again, we're lowering their immune system. If you lower your immune system and have an active infection, it could get much, much worse. And then obesity. I'm going to have a couple slides on that. I will just talk a little about Piedmont. At our center, we have a different approach to obesity than other centers do. A lot of centers look at body mass index. We look at something beyond body mass index. We're actually looking at how much weight are people carrying in their abdomen. Next.
Forgot one. You forgot one reason. We got turned down to the two hospitals because of age.
Right. So
I didn't want to take the chance.
Well, I think age again it depends on different centers, and that's a moving number. So some centers age and some others.
We got Eldridge and Birmingham, and
Yeah.
They didn't say it directly, but they intimated if she was too old.
Yeah, different centers have different thresholds for age, and oftentimes smaller centers may not want to be as aggressive as larger centers, just because of the resources that some of the centers have.
Be careful.
Okay. So body mass index. Can you hit it again forward? Go back, sorry. One more time. No, the forward. Is that it?
Yeah.
Go back. Sorry. Go back more. All right, go forward. Yeah. So when you clicked on it, did you click on like the actual show, not just the slide, the actual? It is. All right. No. So when you do it, you can go through the slides, or you can do the actual PowerPoint with the animation stuff.
Oh, I can't do it in that format.
Okay. Well, if we're doing the PowerPoint, this would actually be an animated slide, but it's not. So basically what this is showing is two people that have different BMIs. And what we do is we look at the distance between their skin and a vessel here called the external iliac vein. So you can see this distance here is longer than this distance here, right? But what's interesting, and Sly would have done a really cool animation of this, is that the person here with this distance has a BMI. You guys are familiar with body mass index of your height and weight. BMI here is 36. BMI here is 41. Right? So most people look at you and say, 41, we're not going to transplant you. But in this situation, this person has less abdominal fat at a BMI 41 than this person here at the BMI of 36. So that's why we don't necessarily look at BMI. We'll do CT scans and look at that as well. So other exclusions, functional status. So what we will do, oftentimes, is when someone comes in, get an idea if they're coming in like in a wheelchair or a walker, then we may want to do frailty testing. And we have criteria looking at age and functional status when we see them. And our dietitians actually look at grip strength. So there's a device you can hold and grip as hard as you can. Also doing what's called sit to stand, sitting in a chair and standing up without pushing with your hands, and also putting one foot in front of the other and seeing how long you can hold out. You can do this for as well. And so that they get a score, and that score helps to correlate with how well their functional status is. Also, oftentimes we'll refer people for a 6-minute walk test. We want to see folks walk at least 1,000 feet over 6 minutes. There have been some studies that have looked at that performance with how well you do after transplant. Also, social workers play a huge role in our evaluation process. So we want to make sure people have transportation support plans. Some of you may live here in Atlanta, but we will be looking at folks to evaluate in Alabama, South Georgia, South Carolina, Tennessee. It's a long way to get here. We recognize that. We know it's a lot of back and forth. We want to make sure that you have enough social support to get back and forth. Also, if people have different histories of psychiatric disease, making sure they're seen by a psychiatrist or a mental health provider. Substance abuse, if you come in, you're cocaine positive, you're not a candidate. We used to rule out everyone with cannabis or marijuana use, but we have a different approach to that now. That we'll look at on a case-by-case basis. Does anybody know why, at least my biggest concern about why it's not a good idea to smoke marijuana after transplant? There's two reasons. One is, right, it can increase your risk of vascular disease, right? Just like smoking tobacco. Yes, it can accelerate. Yeah, but does anybody else know why? I'm not talking. There's a difference between smoking marijuana with the actual bud versus smoking marijuana with the actual oil. When your immune system is lowered. I'm trying to make it a little interactive to keep everybody awake.
What about CBD though?
I'll get to CBD in a second. So when you look at, remember, marijuana is not regulated, right? And so when you look at the marijuana leaf, I have seen cases, this is more when I was out in San Francisco than here, of people getting what's called aspergillus, a fungal infection in their lungs. And so folks will smoke marijuana, it's not regulated. There'll be some evidence of the fungus in the marijuana leaf where if your immune system is normal, it's not going to affect you. But when your immune system is low, the aspergillus gets in your lung, get this big cavitating lung lesion. Now you have to stop the anti-rejection medicines because you could die of this lung infection. So now you're rejecting your kidney, and now you're back on dialysis with big lung infection. So that's a big reason, a concern of why we don't want folks smoking actual marijuana leaf regularly. CBD can interact with some of your anti-rejection medications like Prograf. And so that's the reason why we're not big fans of CBD as well, because of the interactions with Prograf and cyclosporin and some of the anti-rejection drugs that you'll be taking after transplant. And then, adherence. Unfortunately, we have a very big program. Last year, we did 380 kidneys. I'm sure Emory and probably Medical College of Georgia can attest to this as well. Looking at dialysis compliance is very important because that can give you an idea of how well someone is going to be adherent to their medicines after transplant. And so that's why it's really important for us to make sure that we know they're going to be compliant. Because every year we got 3 or 4 people who show up, their creatinine goes from 1 to 12, we find out they haven't taken their meds. And it's really unfortunate because they've blown out a really, really good kidney. But we do our best to try to screen for that, but you're not going to be 100% perfect all the time. Next. So let's talk a little about kidney donation. There's different ways of doing this: living related, so someone that you're related to directly through bloodline; unrelated, paired exchange; and altruistic with a domino chain, or altruistic donation, which is someone who's just willing to donate to the waiting list for the good of helping others. And then we'll talk about deceased donors as well. I probably will move through this quickly in the interest of time so we can talk more about post-transplant as well. So why are they important for living donation? Well, for those of you on the waiting list, you've probably been waiting a while. With living donation, the donor gets approved. You can set the date of the surgery ahead of time. You're not waiting the list for many, many years. If you're pre-dialysis and you have a living donor, you oftentimes can be transplanted before starting dialysis. I know there's some of you in here that may have actually gotten deceased donor transplant before starting dialysis. It's actually very rare to do, but with a living donor, that's much more possible. And then obviously better outcomes. When you look at outcomes with a deceased donor versus living donor kidneys last longer than kidneys that do on the waiting list. And, we put our donors all through a specific screening process that way we have a much better idea of their overall kidney function versus a deceased donor where that person, there's a lot of factors that go into limiting our ability to be able to properly assess that kidney function. Like they may have been in a car accident or shot and their blood pressure goes down. They come in, their kidney function is not optimal. Is it they've had chronic kidney disease or is it acute reaction to the fact their blood pressure is low? There's a lot of moving parts with deceased donor. So here's another slide this is from the SRTR. This is all 2020. They're really behind when they take out these reports. So the 2021 report probably won't come out till the end of the year, early next year. So this gives you an idea of what's interesting here. When you look at donors from 08 to 20, the biggest drop is in related donors. And I'll go into that in a minute. Distant related goes up because I think over time, more and more people are realizing I don't need to get a kidney from a blood relative, and people are learning how to reach outside their families into their communities. Spouse and partners are pretty flat. Paired exchange is this orange line here. It goes up, spikes here, goes down here. I'll go into why that's important. I mean, why that probably is the case. Directed donors, and then other, which may be altruistic donors. Anybody see that? Do you see how there's like a little trend here where there's like a little bump and it goes down in 2020? Mm-hmm. Anybody have any idea or maybe want to guess as to why? COVID, exactly. So, we went through a period of time, as did most transplant centers, from probably March through like May. We really weren't doing living donor transplants due to COVID, and that affected the numbers in 2020. They're on the uprise again now in 2021. So I don't know if everyone here is familiar with paired donation or swapping. But basically that is, so up until about 9 years ago, if somebody came forward and they wanted to donate to a specific person and they weren't compatible, we would just say, I'm really sorry, try to find other donors. But United Network of Organ Sharing, or UNOS, and the National Kidney Registry are two really big registries that look at kidney paired exchange or donor swapping. And so here you have, so here we have pair one. This woman wants to donate directly to this man, but they're not compatible. So here's pair two. This donor wants to donate directly to this recipient, they're not compatible. The simplest way to describe this, there's so many layers. This would be, let's say this donor's blood type is A, this recipient's blood type is B. Well, A can't donate to B. This donor's blood type is B, this recipient's blood type is A. Well, this A donor donates to this A recipient, this B donor donates to this B recipient. So this is a simple kidney paired exchange. And what happens is we try our best when it's just simple like that to have both donors go to the operating room at the same time. We have it worked out now that, the donor here can donate at Piedmont. They literally take the kidney down to the, airport. They put on a Delta commuter flight with the tracking system. And they fly it to the other center while that kidney's being flown here.
Wow.
And so that's how we do paired exchange. The National Kidney Registry is a really wonderful registry. We do most of our transplants through them. It's actually a really cool story. It's run by a guy named Garrett Hill. He's this really successful businessman in Connecticut, wanted to donate a kidney to his daughter probably 10, 15 years ago. Wasn't compatible with her. He's like, there's got to be a better way. They were just starting to do it through the government, but he created his own registry, quit his job. He didn't really need to work anymore anyways. I had dinner with him. It's a fascinating story. And they started this registry, and now there's well over 100 transplant centers that participate. I think they've facilitated over 2,000 transplants already. So it's a really, really impressive registry. Next. So looking at kidney transplants by donor type, again, seeing a nice uptick in deceased donor transplants. I think a lot of that's due to, I'll really be honest, I think it's due to a couple of reasons. One is the opioid epidemic. I hate to say it, but there's a lot of fentanyl overdoses now out there. I mean, that's what keeps me up at night with my, teenagers. I mean, kids are going to try stuff, but, people are lacing fentanyl with different drugs. And, I have talks with kids all the time. You've got to be really careful. And, we have the Organ Recovery Center here at Piedmont now, and I'm seeing sometimes I have to go down and evaluate those donors, and a lot of them are donated due to fentanyl overdoses or drug overdoses or opioid overdoses. Also, I think that there's hopefully improvement in communication in the community about the importance of organ donation. Again, you can see living donation, you get that bump down in 2020, what you talked about earlier is likely due to COVID. So this is, again, through the SRTR 2020 data report on looking at the trends in deceased and living donation, which I guess kind of frustrating though, if you go back, is this line's been pretty flat, but it does have a nice little bump here. Hopefully it's going to bump back up now, but really trying to get the word out to have more people be living donors, which I'm going to talk about in a minute. Okay. So, living donation. How do you talk to someone about being a donor? It'd be hard for me to walk up to Hannah and say, "Hey, Hannah, I'm on dialysis. Would you donate a kidney?"
Yeah.
Right? I mean, for those of you who've been through the process, that's not. It's a really hard thing to do. So, I used to have the approach when I would see folks that had potential living donors, blame it on me. Here's my card. Tell them you went to Piedmont, you met Dr. Wolf, and Dr. Wolf was the one really pushing you to find a living donor. So that maybe takes a little bit of the awkwardness out of that conversation. Education. So now I used to give this whole long spiel. I probably do a few of you in this room about how to find a living donor. Here's what you should say. And then I realized, I'm like, you guys are being inundated with information when you came into the evaluation. There's no way you remember everything I just said. So now we have a paper, basically 2-side sheet of paper I put together, how to find a living donor, bullet points of exactly what you can tell potential donors. And, basically that living donation is safe. The recipient insurance pays for the donor's evaluation, donor surgery, and follow-up care. The donor surgery is laparoscopic, camera-assisted, minimally invasive. Typically, donors are going home to one to 2 days after donation, and within 4 to 6 weeks, they're back to everything they did before they donated. And then also, I saw a recipient the other day who was hoping her sister could donate, may not be able to donate. She culturally said, it's really difficult in my culture for me to go out and even approach anyone. So we talked about having a donor advocate and having her parents and her sister advocate for her, because she's a 42-year-old working full time, great candidate. So it talks a lot about how do you advocate and have others advocate for you. And so in the last 2 to 3 years, I've actually become a much bigger fan of utilizing social media. I used to never believe in this until patients started coming in and finding potential donors through Facebook, Instagram. I'll talk about this microsite. Even, has anyone heard of Nextdoor?
Yeah.
It's like a community, when people post, hey, these kids rode their bikes through my yard, or someone's speeding down the street too fast. And but this woman actually in South Georgia posted on Nextdoor and found a donor that way. I couldn't believe it. So it's really, talking about a brief history of your story, educating others, using the sheet I give out, those bullet points. And then I also tell folks this, like one time I evaluated a donor. They come in and I read through their question. I said, oh, I realize you don't know your recipient. What brings you in to want to donate to this person? And I never forget, it's the first time I heard this. She said, my cousin shared her next door neighbor's post on Facebook and I want to help this woman. And she donated her kidney to her cousin's next door neighbor. Now, had the cousin's next door neighbor not shared that story on Facebook, it may never have happened. So I do tell folks that if you're going to do this on Facebook or Instagram, ask other people to share it to help you.
Get LinkedIn too.
Sure, LinkedIn. Living Donor Champions, a friend or relative to share your story in person as well as online. I'm going to talk about the microsite in a second. Just anybody have any questions about that? Because this is important. Yes.
Not about that. I'm sorry. You mentioned, I'm kind of going back.
No, that's fine.
BMI, obesity. My mom been needing a kidney, started over a decade ago when I initially went in to try to donate a kidney. The doctor was saying that, I need to lose weight and things like that. Is that changed now?
No, you bring up a good question. I actually didn't talk too much about donors and weight. So we have much stricter criteria for donors. Because remember, if you're going to donate your kidney, we want you to live the rest of your life with one kidney and do okay, have a normal life. We've become much more lenient on BMI criteria for donors. We used to have a hard stop at 30 for BMI. Now we're looking at donors up to BMI of 35. It would be a lot of the same kind of looking at, height and weight and getting more of assessment that way. And so our living donor coordinators will typically ask a lot of questions about that. And sometimes we may say, okay, if you have a BMI of 35, 36, how about call us back after you've lost X number of pounds? And then we can try to do a reassessment that way. Yes.
Hannah has some sample letters that I use to try and get charity kidneys. And I'm sure Hannah will be able to share them. If not, I will.
Okay, thank you. Yeah. Yes, sir.
My question's kind of crazy. I'm just curious. If I have two good lungs, why can't I donate a lung to get a kidney? I don't know. I don't.
So that's an interesting question I never had asked before. So again, I think going back to if we're going to allow someone to donate their kidney, we want to make sure, again, as you go back to that person lives the rest of their life with one kidney does okay. And when you go and you decrease your lung capacity by half, again, I'm not a lung expert, but your risk of developing, lung issues does go up. There are living lung donors out there, but typically, once you donate an organ, it puts more stress on the other organs so that if you were to donate a kidney after a lung and only have one lung and one kidney, it's going to put tremendous stress on both of those organs. But it's a good question. I haven't really thought that one through. I know that we had have done some living liver donors, and again, we've not ever allowed someone to donate part of their liver and a kidney, just because it puts too much stress on the body overall. So you're saying if you're a dialysis patient or chronic kidney disease patient, could you donate a lung and that would allow you to get higher up on the kidney list?
Right.
Yeah, that would put way too much stress on your body, because remember, with dialysis and chronic kidney disease, you have major fluid fluctuations on dialysis. And if you get fluid overloaded for any reason, it may not be your fault. Maybe they didn't pull off enough fluid on the session or whatnot, and you get pulmonary edema or fluid overload into one lung, that's going to be life-threatening versus two. So that would be a tremendous stress on your body.
Right.
Yes, sir.
I know we're talking about kidneys, but you just mentioned something about a living liver.
Yes.
So doesn't the liver regenerate?
Yeah, that's a good question. So, yes. So we have done living liver donors, and what the living liver donor does is they donate part of their liver to their recipient, and the liver has an unbelievable ability to regenerate itself. Yes.
Well, you can donate part of your liver to get a kidney.
Again, putting too much stress on the liver based again on fluid fluctuations and liver congestion and other things like that.
You can donate your white cell.
Yeah, right. Yes, sir.
I'm sorry, are you still doing,
Hep C. We haven't done as many lately, but we're not, there are programs that do look at putting in hepatitis C positive donors into hepatitis C negative recipients, with the understanding that those recipients are going to have to be treated for hepatitis C afterwards. We were in a research protocol for that, but we're currently not doing that. We're maybe looking going back to that. Honestly, we haven't done it as much lately because of the fact that and I'm going to go into organ allocation changes in a minute, our numbers have gone up so rapidly that we haven't felt that we've had to go dip into that pool. And most now hepatitis C donor kidneys are going to hepatitis C positive recipients. So I'm just going to gloss over this. This is the National Kidney Registry I talked about earlier with their microsite program. And basically, it's really cool. This is a free website that they'll create for you. And you just have to talk with your living donor coordinator. They'll help you set up with this website. On the website, you can put information about yourself, your family, pictures. What I like about this website is two things. Number one is that on there's a link that you can go directly into one of our websites. You can do an online questionnaire to be a potential donor if someone sees this site. And the other nice thing, you go to the next slide, is about 2 weeks after you create the site, you get 250 free business cards in the mail with your website on them. So you can hand them out to folks. Instead of saying, hey, Hannah, will you donate a kidney to me? I'm just going to pick on you the whole time. I can say, hey, Hannah, check out this website I put together. Here's the website on my card. Maybe take a look at it and share it with your friends on social media and tell everyone, to take a look at it. So I like that as well. I don't know. And what National Kidney Registry does too, which I think is pretty cool, when you create these microsites, so oftentimes I think they're contacting potential recipients still and offering them to have mentors who have gone through the living donor process. So again, the National Kidney Registry is a really great resource. They've been amazing for patients. This is a sample about a boy named Javian McCoy, whose mom put this together on a microsite. Some pictures of him, a little bit about him, why he has kidney disease, why they're looking for donors. And then at the bottom here it says, can you help Javian by donating a kidney? And you can basically click on here, learn more about kidney donation, or register to donate for him. So that's the online questionnaire.
And what's the name of that site again, sir?
It's called through the National Kidney Registry, and it's microsite. So it's a microsite Honestly, the easiest way to do it is to contact your transplant center and ask to get in touch with the living donor coordinator assigned to you, and they can help you with getting that set up. But I think the microsite's a really great resource. So real quickly about organ allocation. Up until about 2 years ago, when a kidney became available, with certain exceptions due to people that had high antibodies, that kidney would stay within the organ procurement organization. And so for just to simplify it, the organ for us, the OPO, I'll refer to as OPO, is the 3 centers in Georgia, Piedmont, and there's other 2 centers. I'm just kidding. Piedmont, Emory, and Medical College Georgia is now called Augusta. And then if there's no adequate recipient in that OPO, they'll look at regionally, then look at nationally next. But here's what we argued for in Georgia and other parts of the country. When you look at the population of the southeastern United States, there are 10.6 million people living in Georgia at that time. 440 kidneys a year came out of Georgia, okay, donors. And that meant that there was only 1 kidney for every 24,000 people. But if you look in South Carolina, there's 1 kidney for every 18,000. Tennessee, you can see 1 for every 14,000. North Carolina, 1 for every 16,000. Alabama, 1 for every 19,000. North Florida, 1 for every 18,636. So basically, it was hard if you lived in Georgia to get a kidney in Georgia. That makes sense? So basically, all the surrounding organ procurement groups or donor service areas were producing more kidneys per capita than Georgia. Well, that's not fair to anybody in this room if we're all here from Georgia. So we were very fortunate, and this was the change that they made about 1.5 years ago. So starting in, it was supposed to be December 2020, but it was February 2021, they changed how they allocate kidneys. So now when a kidney becomes available, they look at all centers within a 250-mile radius of where that kidney is being procured. Okay? So now, if you have a kidney down in Panama City or the Florida Panhandle or Tallahassee or parts of Jacksonville, and there's somebody who's been waiting in Georgia longer than the Northern Florida programs, those kidneys go up to Atlanta or Augusta. Most of Tennessee, they're part of Alabama, North Carolina, South Carolina, up into Kentucky. You pretty much have like most of the Eastern Seaboard along here too, even, encompassing Charlotte. There's a lot of big cities that are in there. So as a result, go back. So as a result, our numbers increased tremendously. To give you just some background, I started here 15 years ago. We're doing about 130 to 150 kidneys a year. And our goal was, all right, one day we're going to get to 200 kidneys, like 200 kidneys and 100 livers. That was our big goal. Well, last year I had alluded to earlier, we did 300. When you look at liver, kidneys, kidney pancreases, and kidneys, we did 380 kidney transplants. And at Piedmont, we were the 5th biggest program in the country last year. And I think Emory, it's kind of like a back and forth with Piedmont and Emory. I think Emory was like 350 something, and they were like the 9th biggest program in the country. So
we have 300 Piedmont, 300 with
in the city of Atlanta, there were almost 800, like well over 700 kidneys transplants performed in 2021. Yeah, I know, it's incredible. Like I trained at UCSF in San Francisco. My transplant fellowship year, the Kaiser program shut down there. All these kidneys came in. We did like 400 kidneys that year. And if you had ever told me that we would do more kidneys than UCSF, I just would have laughed. And we did last year. So it's really great for folks in Georgia, which is why those earlier slides, when I said those waiting times are wrong, this is a big reason why those waiting times are wrong. So, yes.
So with this new format, this is kind of
It's an excellent question. And I've had this question by a lot of nephrologists. Personally, I think it does. Now, when I say that, I'm saying, is it worth it for you to go to Jacksonville, to Vanderbilt, to UAB in the Southeast? I think that there's much less advantage. So we get a lot of referrals from Alabama. And I have another slide or like a sheet I show. There's a picture with Atlanta in the middle. There's another one with Birmingham in the middle. And I do 2 circles. And if you look at Birmingham, there's a lot of overlap, right, in the middle here. And the part that's not overlapped for Birmingham, for example, is a lot of Mississippi. Well, Mississippi's pretty rural, right? It's not a lot of people live in Western Mississippi. And so I personally, when you look at the 2 population centers, like you draw lines on each center, you can see that there's not a big advantage to go to Birmingham. Again, Birmingham's a great program, right? You got a lot of good programs in the Southeast. I mean, you have two excellent programs here in Atlanta. Nothing against Emory. I mean, we're a little bit better, of course. Just kidding. But you've got two great programs in Atlanta. You've got some really excellent programs in the Southeast. I think though, if you have the resources, there'll be other parts of the country where the waiting times are shorter. Okay. If you go to Iowa, let's say you draw a line on I don't have the waiting times in front of me, but you can go on the SRTR and you can look at all that data and you can see, okay, this program here, I actually could save a few years of waiting time. Maybe but it's going to be somewhere farther away.
Is that map on the SRT?
No, this is a map that I just created. Well, actually, I can't take credit for it. All you got to do is, and I got to give credit to John Humley, one of our transplant surgeons, for this. You can basically go like a mapping program, and you can stick, you can go to any location, and you can have it draw a circle around it. That's kind of what we did. That's how I did the Birmingham one. I don't remember the exact program I used, but it was like one of those. Yes.
In your personal opinion, what would be to increase the awareness of living donors? I think that needs to be done throughout the country.
Yes.
Yeah. Cancer, I see cancer commercials all the time, or, as far as making people aware that living donors, people can be a living donor for organ transplants. I think education is key that. How is Piedmont and Emory getting that out to they're not?
So so to answer your question, I think a lot of it's more of a grassroots effort. And I actually do spend a lot of time talking to recipients that come through about living donation. And a lot of it is publicizing it through going to community organizations, church, or whatever, if you're different community organizations, also looking at social media as a way to publicize it and using those different avenues. I agree. I wish there was a more of a broad way of publicizing it. Can I finish, please?
Sure.
Thank you. I think a lot of it with cancer has to do with money, right? There's pharmaceutical companies, other companies that are willing to invest the money to pay for the ad space to be able to do those commercials. I hate to say it, that's what kind of runs a lot of things all around. So I do, really work with a lot of recipients that I see about trying to find ways within your own community. We also, if you look on the sheet of paper that I give out, I can't speak for other programs because what we did our program, there's a lot of websites. We have YouTube videos that talk about, creating champions, different, organ champions. And like I talked about earlier, friends or family that can go and be your living donor champion. We have those in English and Spanish. One of my partners, Jose Lizcano, did it in Spanish. So there's a lot of good resources, websites you can look at. But again, I hate to say it, it does a lot of it falls upon the recipient and their families to do that. But I agree with you. I wish there was a way that
it's all about license. The only time you see that question is asked when you go and get renew your license or when you.
So so you're talking about, so there's two things. One is about promoting living donation. The other is about promoting people to be organ donors.
Yeah.
So there's an interesting study that they did in New Hampshire where they actually trained folks that worked at the DMV, 20 minutes of training about when somebody comes in to apply for a driver's license, to give them an extra 3 minutes little talk about why it's important to sign your organ donor card and how you can save 7 lives. And they actually found that the number of organ donors in New Hampshire went up. There's easy ways to do it. It's just a matter of, places like the DMV are the places you do that at. And so that there are ways of doing it. Yes.
There are a couple other ways. There's a group out of Brooklyn, I think you know about it. It's called Renewal, which helped find Sherry Kennedy from active donor in Memphis, Tennessee. Right.
When you look at the fact that there's hundreds of thousands of people on the waiting list, a program like Renewal is going to account for less than 0.1% of that.
Well, while we were in New York a year ago, Montessori Hospital during Edward actually put a commercial on national TV, or at least the metropolitan New York area, to solicit living donors.
Right.
Now, I don't know why Piedmont and or Emory can't follow the same suit by actually spending money to put a commercial on national television in the Atlanta area or Georgia to solicit living donors. By the same token, there are so many commercials on TV today that promote drugs. Why the drug companies that we have to purchase for the rest of our lives for anti-suppression drugs don't put out commercials for living donors?
It's all money. I mean, you know the answer to that. It's the fact
You
that
have to wait to talk to these companies and say, hey, look, we need your help to put out commercials to get us living donors.
They don't make no money there.
yeah, it's all money. That's the whole thing.
They'll make more money.
There's no money in that. Okay, let's skip through. I'm not going to talk about KDPI. Let's skip through. So skip through that. Go back. So let's talk a little about post-transplant. I'm going to skip through the EPTS and KDPI. Living with a kidney transplant. So I alluded to this earlier. It's so important for those of you who've had a transplant to talk about compliance, right? Compliance. It's not unusual. Unfortunately, I see it more often than I wish, where folks that are 5, 6, 7 years out from transplant, they get complacent. They're taking their meds. Bills come in. Maybe the financial stressor. I'm going to spread out my monthly dose of medicine. And then they don't get their labs because the labs cost a lot. And I get it. Things are expensive, which is one of the many reasons that we're really fortunate at the Georgia Transplant Foundation. And any decent transplant program should have will have social workers that you can contact should you get into trouble with this down the road. And at some point, usually the post-transplant side mentions the patients as they're getting a little bit farther out. So it's just really important that you always make sure that you take your medicines and you get your labs drawn according to what is recommended by your transplant center. New medicines. We'll get into one medicines for COVID. But just call your coordinator if you're prescribed a new medicine. 90% of the time they're going to be fine, but it's that 10% where they interact with one of your anti-rejection drugs that can get you into trouble. Also basically looking at infection and malignancies. It's really important that you do your best, because those are side effects of anti-rejection drugs, right? That you do your best to try to avoid people that are sick. I don't want people to feel like they have to live in a bubble, but if you're going to go out to the store, wear a mask. If people want to come visit you, that's fine. Maybe sit outside, have socially distanced. Buy hand sanitizer. Use the hand sanitizer. People come in, hey, you mind just quickly using the hand sanitizer. You don't know where people's hands have been before they came in to see you. Age-appropriate cancer screening. It breaks my heart when at least once or twice a year somebody comes in with, and this a lot is said to do with COVID, people not getting their regular checkups. Someone coming in with advanced breast cancer after transplant, advanced colon cancer, that could have been prevented had they had their scheduled, mammogram or colonoscopy. So that's really important. Please don't stop getting your regular checkups. Establish care in the primary care provider to do this. Diabetics, they're on insulin. That's a constant struggle for us, is trying to make sure that you can work with a local provider to adjust your insulin. Because as you know, post-transplant, as time goes on, we're seeing you less and less often. I tell folks, the same things that got your native kidneys into trouble, high blood pressure, diabetes, will affect your transplanted kidney if you don't manage those. Some people in this room have heard me give them that speech already. Went outside, wear sunblock. I had just a case that everyone in my group will not forget about. Just the nicest guy had a living donor transplant from his lifelong friend, and 2 years later had this metastatic squamous cell cancer in his, basically throughout his scalp, and he ended up dying. It was metastasized and it was awful. He wasn't that old, but had he covered up and worn sunscreen, there's a good chance he could have prevented it. So it's just, I can tell you stories about all these just to put it in perspective for you. And then one of my areas of interest is telemedicine or telehealth. And so post-transplant, I recognize, and I'm very sensitive to the fact that, we are transplanting people from far away. Some people have to drive 3 or 4 hours each way to see us. That's a lot of money and gas and a lot of time. And so one of the nice things, and again, this is Piedmont, and I'm sure Emory and Augusta, a little smaller catchment area, has this. With all the new Piedmont hospitals opening around the state, we're trying to utilize those labs if you live near one of those hospitals. to be able to use that lab to get your blood drawn. And also looking at doing telemedicine or telehealth. So, ideally, if somebody lives in Savannah, they can go and get labs at Memorial, which is not a Piedmont hospital, but we can get their labs through our electronic medical record system. Or actually in Augusta, Piedmont, they're Macon, Columbus, Piedmont Henry, just south of Atlanta, Cartersville, East Side, which is up 85, trying to make sure I don't forget any of the different Piedmont facilities. And you can get labs there, let's say on a Monday, and then we could do a telemedicine visit on Thursday, and we can go over your labs with you. And once you're more than usually 6 months out and you're stable and doing well, we can do a lot of visits that way. As I mentioned earlier, I don't know if anybody on this is from Alabama, but I felt so strongly about this that with our Alabama patients, and I'm on a couple national groups with telemedicine looking at this. I actually went out and got an Alabama medical license so that I could be able to oversee our nurse practitioners or myself see folks in Alabama with telemedicine. So that way, with an Alabama license, I can legally do that, and so that helps to provide access to care. On the evaluation side, yesterday I did our first pre-screen telemedicine visit in Savannah. So we had an employee on one end, I was on the other, and we pre-screened. I just did about 4 or 5 patients because it was more of a trial run. And if those folks were good candidates, we bring them to Atlanta to complete their evaluation in Atlanta. We're pretty much in Columbus doing pre-screens, and Athens starting in December. We'll be doing pre-screens at both of those locations with telemedicine. They still have to come to Atlanta to complete their evaluation. We can at least do the initial evaluation in those areas with telemedicine. It allows us to kind of be in 2 places at once, so that's been really helpful. Next. So real quick about COVID. Is it already time? I'm going to gloss through COVID real quick. All 3 programs in Georgia require that you be vaccinated for COVID before getting a kidney transplant. This is just a quick diagram about COVID. For those of you that are not familiar with the vaccine, it's the two main companies that make the COVID vaccine, Pfizer and Moderna, both use messenger RNA technology. Basically, they create the viral part, the virus DNA, RNA, messenger RNA. It goes into the cells. It tricks the cells into thinking that you're infected with COVID. You create the spike protein, and then the cells break down the messenger RNA in the vaccine. So when you're given the vaccine, everything's broken down within 2 days. So whoever's spreading all these things about people are getting COVID and they're getting sicker and it's causing all these deaths, this is a whole other topic. But that's really not the case. And so that's how a little bit about how the vaccine works. In the interest of time, I'm not going to get into too much detail about that. Next. There are gazillion studies that have looked at this now, but if you look at folks that are vaccinated, unvaccinated, okay, this is percent survival, 100% survival, 0% survival, 0 days of time of getting COVID and out to 40 days. If you are vaccinated, you're much more likely to live than if you're unvaccinated, okay? You see this gap here at 20 to 30 days? This is the difference between people vaccinated and unvaccinated who get COVID infections and how long they live. There's tons of data that look at this. So getting vaccinated is important also because do it before transplant, because after transplant, if we lower your immune system, you're less likely to create those spike proteins to the vaccine. Next. This is the newest thing. This is like the hot topic now, post-transplant with COVID is Evusheld. Has anybody gotten their Evusheld shot in here? No one has gotten Evusheld yet? Okay. This is important. So I say you got it, right? Yeah, the Evusheld?
I was doing it for transplant.
Immediately after. So Evusheld is basically it prevents COVID. You're injecting these antibodies that basically attack that spike protein. And this will help you prevent getting significantly sick from COVID. Not necessarily preventing getting COVID, but getting really sick from it. And it's 2 shots in the butt, 2 different drugs. Yep, in the butt. Not like in the sides of your butt, not the actual, in your gluteal area.
She got that before she.
Yeah. So, pardon me? Yes. So basically, in the sides of your buttocks, you should have been more specific. And this is, you cannot be currently infected with COVID. No known recent exposure to COVID can be given to folks who are immunocompromised. Okay. And this will help prevent significant infection from COVID. And once you get it every 6 months. So now when we're transplanting our patients within the last month, again, this is probably like the one important thing I can teach you guys today. Before folks leave the hospital, we are offering them the Evusheld vaccine right after transplant. And for those that haven't had it, call your coordinator, ask them how you can get it. The availability of this is much better now. Even if you've been vaccinated, if you've not been, it's been a while since you've gotten your vaccine, this does not supplement getting vaccinated, okay? But it helps to add additional protection for the COVID infection, yes.
How soon after transplant can you get the COVID booster?
So we ask folks to wait 3 months after transplant to get the vaccine booster. Same with the flu shot, because your immune system's a little bit too low to get an appropriate response to the vaccine, but the Evusheld you can get right afterwards, yes.
This is something you recommend for the rest of your life?
Good question. I think it really depends on how long COVID is a major issue in our society. But for now, I recommend it. Yes.
That's what I was gonna ask. You said every 6 months. I was gonna say every 6 months for how long?
So as of today, I think it's every 6 months. And then until we redirect folks otherwise, or the CDC comes out with other recommendations. Yeah. Yes.
So you're not required to have your booster before you actually.
No, we're not currently requiring the booster. We're requiring, it just logistically became very hard to track that. We highly recommend it, but we're not requiring it. Yeah. Oh, last one, Paxlovid. Sorry, I know I'm running over. This is important. Does anybody know what Paxlovid is? Has anyone ever heard of Paxlovid? So please, if you are post-transplant taking Prograf, cyclosporin, sirolimus, everolimus, and Vars is the long-acting Prograf. And if you do get COVID, okay, and you go to your primary care doctor and they say, we want you to take Paxlovid, call your coordinator, okay? Probably half a dozen people have been admitted because you know what happens to get Paxlovid on Prograf? Your Prograf levels go to 40 plus because Paxlovid inhibits the ability of your body to break down Prograf. And so folks are coming in shaking like this with creatinines up, and we find out they've gotten Paxlovid but not stopped their Prograf. There is a way to receive Paxlovid and do this. We have a protocol in place, but if anyone offers you Paxlovid, if you get infected with COVID, please call us.
Shouldn't your physician be aware of?
It's hard because not every doctor is familiar with drug-drug interactions for anti-rejection drugs out there. This is a very specialized area of medicine. So many are, and many would say check with your transplant team. But if you're coming in, you're sick, and you're in an urgent care center, they're super busy. Oh, you're immunosuppressed here. Take this Paxlovid. It'll prevent. This is what the CDC says to help prevent you from getting too sick. And then they move on to the next patient, right? So that's why I think it's really important just to call about that. Yes.
How long has this drug been in place?
Just a couple months.
My transplant center, which was shared. Florida. They've never heard of it.
This has probably been around 2 or 3 months, I think.
Wow.
So the Evusheld and Paxlovid are new. This is I just put these slides together a couple days ago because this is all very new. Next. So as we know, kidney transplant improves survival and quality of life. With new organ allocation system, folks in Georgia have better access to kidneys. Do everything you can to improve your chances. Living donation. I didn't get into the high KDPI, but multiple listing, I put 2 question marks next to, because now it's harder to say if it's really advantageous or not. And if you have not been referred yet for a transplant evaluation, don't depend on others. Call your local transplant center, get yourself referred. And then reach out, have friends and family help you with being living donor advocates for you. Don't worry about blood types with a kidney paired exchange. Learn more about financial support, travel options, local care at your evaluation, and make sure, as we talked about COVID, getting vaccinated against COVID, and know your treatment and prevention options for COVID. I think that's it. Thanks. Sorry, I rushed through the last few slides, but I didn't want to fall too far behind for today. Thank you. Thanks. Any last minute questions? I don't want to get in too much trouble running too far behind.
We are actually taking questions on the chat that I'll send to you. So if you have questions for Dr. Wolf,